Good afternoon, everyone. Thank you for joining us for Public Health Sciences seminar today. I'm Brad Stoner, the department head, and as is our custom, I would like to begin with a land acknowledgement. I acknowledge that Queens is situated on traditional Anishinaabe and Haudenosaunee territory, and as uninvited guests, we are grateful to be able to live, learn, and play on these lands. It is my distinct pleasure and privilege to introduce our speaker today, Dr. Will Pickett. Who is the former head of public health sciences here at Queen's University. Dr. Pickett is an epidemiologist with longstanding interests in the health of children, rural and agricultural health and injury prevention, and determinants of health. He has supervised approximately 100 students and trainees to the completion of degree requirements and has taught epidemiological methods at the undergraduate and graduate levels. He holds grants from CIHR and Public Health Agency of Canada and is lead investigator of the Canadian Health Behaviour in School-Age Children study. And today he's going to be talking about this project, Health Behaviour in School-Age Children, reflecting on a 35-year legacy at Queen's University. Please join me in welcoming Dr.
Thanks very much. It's really special to me to be back here. I haven't been back in, I think it's been 3 years, and this and this community were very, very important to me. So really glad to be here. And I've really one purpose through this talk, and it's to let you know of the existence of this sort of little gem that's at Queen's University you may not know about, called Health Behaviour in School-Age Children. And I'm going to do a little bit of reflection. The long title was something like Reflecting on 35 Years. This is something that's been around and been a resource for students and faculty for a long time. And it's of great value. So this is what we're going to do. I've got about half an hour prepared, and then perhaps we'll have a little conversation. What is HBSC? I'll give you some international perspective because it's a Canadian study embedded in an international network. Show you just some examples of national findings, the sorts of information that's gathered in this survey, and reflect on the importance, especially to this Department of Public Health Sciences. So HBSC in 30 seconds. It's a school-based survey. Kids 11 to 15 years, so sort of pre-adolescence, adolescence. It's international, and it's in Europe probably the most major survey of its type, probably in the world. And Canada sort of tagged along for 35 years on it. It's affiliated with the World Health Organization, and in Canada it's funded by the Public Health Agency of Canada. We partner with health and education authorities across the country, and it's directed at Queens. So it has a bunch of aims internationally. And the first is to do what we're doing right now, raise awareness of adolescent health development and its importance. We gather data cross-nationally. So there's actually 51 different countries in it. It's pretty cool as an epidemiologist to look at the data and reports from like 300,000 or 400,000 young people in 50 countries, and to make sense of that data. It's a platform, and then it's used as a platform to spawn other things and advance theory and scientific development in the adolescent health field. It's a really practical survey. It's used to inform policy, inform practice. And there's this great international network. It's like a little United Nations that once you become a member of HBSC, you're part of. So you have this international network of 450 scientists that you work with. And it's inherently collaborative. So just a little overview, WHO collaborative project. It started with 3 buddies getting together at a bar somewhere in Denmark or something in 1983. 3 like-minded like-minded friends and said, if we're going to actually be studying adolescent health, maybe we should have a questionnaire and a method that we have in common and that everybody uses. So it began there, and now it's got this global reach, more global reach, 51 countries and regions, and a lot of people involved. We use a standard protocol to collect our data, standard sampling methods. So essentially, we go into schools and document the health experiences of the kids that are in the right age ranges. Standard sampling strategy, it's children nested within schools, nested within provinces, nested within countries, nested within the study. And the recent survey, there was about 280,000 children participated, about 22,000 in Canada. So as I said, it started in '83. They've done 11 cross-national surveys now. So every 4 years, there's a new survey. So we just finished sort of at the tail end of the pandemic, the most recent cycle in Canada, which was cycle 9. And yeah, there's a lot of people involved. Here's a picture of the countries that are in it. My geography isn't as good as I thought. I was trying to figure out some of the missing ones. Russia's part of it, but they have been purposely excluded from the network since they invaded Ukraine. So that's 50 countries. The States was in it for a while, but then for funding reasons, they withdrew, but a lot of countries. Our hope through this work is it guides policy and practice. So an example of that, it informs things like physical activity guidelines. It informs anti-bullying and violence measures. It is a basis for the UNICEF report cards. If you've ever seen those, UNICEF every so often gives the state of children in the world, and they use data to do that, and HBSC is one of the primary data sources. So lots of different applications. It studies health in context, and it makes it different than other surveys. It doesn't just collect information on smoking and drinking and behaviors. It does it in context. We also collect information on the usual environments that kids are in. So that would be schools, their neighborhoods and communities, and their families. So that's really, really valuable for etiologic research and determinants of health type things. It builds on early years research. There's lots of surveys out there, but there's very few in this sort of prepubescent, 11 to 15-year-old age range. So it's a neat snapshot of life at a critical and sensitive period of development. And data will never improve health in all young people, but it provides a foundational evidence base. You can build initiatives and target initiatives to improve health. So there's lofty aspirations. Value of international data, country rankings. Our federal government's super interested in where do we stand on cannabis use? Where do we stand on any basic behavior of interest? And they use that at the sort of parliamentary level. National and international trends, you can start to see what is universal in the growth and development of children that crosses cultures, crosses countries. And that can be very powerful information. It's got a developmental focus, so we watch behavior sort of with age and with stage of development to see the trajectories that young people are on. And there's more and more a gender focus on health experiences. And one of the most interesting things it can be used for is we have measures of sort of affluence and things like that. So it's used for determinants of health research focused on health equity. And you may not know it, but you've got some real expertise in this department in this area. So this is a fancy quote from somebody fancy from the WHO. HPSC provides a springboard to step up existing initiatives, development policies to counter the ongoing challenges young people face. In my own life and research, I found it a springboard. It's a starting place to ask questions. You can then go on and develop grants and ideas using the data to advance those questions. And it's a really, really good starting place and platform for your research if you're interested in pediatric issues, which I am. So just a few examples of international data snapshot. Let you orient yourself to this. This is the 280,000 kids. And one of the things that we measure is whether they've experienced an injury. Injury is a really important public health thing. And we can describe those injuries by age, by gender, by level of affluence. And the pattern you see here is boys have a lot more injuries than girls. You may ask yourself, why aren't there any gender diverse kids in this survey? Well, there actually are, but it's really actually interesting working in a network of 51 countries with different backgrounds. So we were at a meeting in Lithuania for HPSC this past spring. Gender diversity does not exist, according to official policy. You cannot ask those questions. Probably in 15 or 20 countries, that's the same. So while we in Canada think of ourselves as, I think, fairly progressive, and we do have measures of gender diversity, we don't actually have them. We don't have them internationally. So it's interesting. We've got measures of mental health, and this is just the kids who are reporting. It's the prevalence of a standard indicator of psychosomatic health, multiple health complaints. And you don't have to worry too much about the numbers here, except we can start to map developmental patterns. You can see, especially in the girls there, the prevalence of psychological complaints is going up with age, and it's different than boys. And it doesn't matter what indicator you look at when it comes to mental health. We see this marginalization or disadvantage in girls and young women. And you see it in all of the countries. And I find that fascinating. And I don't know if they're gendered questions that girls and young women are more likely to engage with, or it's a real phenomenon. Probably more likely the latter. But certainly there's something very important there. Yeah.
Sorry, I was just wondering what the three bars represent within girls and within boys.
Pardon me?
I was just wondering what the three different bars are.
Oh, about 13, 15-year-olds. Sorry, must have got cut off. Yeah, so they always present the data internationally in the 11-year-olds, 13-year-olds, 15-year-olds. So it's not overwhelming. We've got measures of social media use, and don't worry about the different behaviors here, but it's really fascinating. The percentage of kids who are basically on their phones or online virtually all the time is upwards in some countries. 30–40% of kids are actually connected all the time, and that's got to have health implications that are interesting. We have the ability to engage with such questions in HPSC. We've also got measures of traditional things, substance use, so alcohol use, drunkenness, smoking, cannabis use. Canada leads the world, or leads these 51 countries in cannabis use, and every cycle we have to defend why that is. So does it achieve its aims? Internationally, it is the major health survey for this age range in Europe, and it's a very important survey in Canada. It is actively used by government agencies, by NGOs, within school systems, within the health system, within the public health system as a foundation to make evidence-based decisions. I think it's valuable. Very proud of the collaboration with UNICEF and UNICEF Canada. It's used internationally. There's something called the Innocenti Center. As they call them the UNICEF report cards and the UNICEF indices, but it's HBSC data. They also have a UNICEF Canadian Index of Wellness that you'll see nowadays. That's HBSC data. It's used by OECD, Organization for Economic Community and Development, I think, a big quasi-government organization in Europe. And the WHO, these are amongst the most read and downloaded reports that exist for the World Health Organization. I bet you a lot of you never heard of it before. We also do things nationally. So just a brief history. It started in '83 in those three countries, and for whatever reason, Canada got interested in the late '80s, and there was a fellow named Alan King, happens to be a father of a prof here, who started this thing. He was a sociologist interested in children out of the School Faculty of Education at the time. And Dr. King ran it out of a group called the Social Program Evaluation Group for about 15 years. It was taken over by another colleague, Will Boyce. Will left the university, another fellow named John Freeman in education, and myself took it over. Then John up and died. So it's me and a colleague, Wendy Craig, from psychology, who co-run this. It's out of Queens, but we have partners at Waterloo, UBC, McGill, University of Prince Edward Island. I'm going to forget some. There's 8 or 9 different institutions that partner with us. But the data collection is centered just on Berry Street here. Funded by the Public Health Agency of Canada. It was originally Health Canada, so they give us an ongoing grant to do this work. They don't give us any money at all to do research. They give us money to collect the data, go into the schools, do a national report. Anything after that, we have to go and get funding from CIHR, something else to support it. But they support it, and then they also support this agency called the Pan-Canadian Joint Consortium for School Health, which is basically government that oversees the school system across the country. And they partner with us, and they tell us about what they'd like on the survey, and they provide us support so we can actually do the work. Our last cycle, I'm going to present 2018 data. 2022 data just complete. We had a real challenging time because of the pandemic. You can imagine, pretty hard to get into schools in the last 2 or 3 years, and even post-pandemic, the school systems are all in disarray, and it's hard to get into schools. But we've just completed the newest cycle. I think it's about 300 schools, 26,000 children from across the country. But I'll show you 2018 data, and we can split it by grade and gender. You see we have gender diverse. Remarkably small proportion. It's more than double that next cycle. So that's going up. And we have data on factors that influence health, so contextual influences, homes, families, communities, their school experiences. So here's some data. We've got all sorts of indicators, but I feel understood by my parents, boys reporting this. And you can see, if anything, things are getting a little bit better over time, but very powerful. For all these indicators, you can actually track temporal trends within age groups and by gender. This just happens to be, whether boys are feeling understood. We've got physical health indicators. So sleep We've got measures of sleep and sleep hygiene on it. And you can sort of map the average amount of sleep that kids are getting and compare it to guidelines offered by physicians and clinical groups. And about 80% of kids are getting the recommended amount of sleep, 20% not, but it's getting worse. And it's getting worse with the advent of the constant connection to our devices. These are data that colleague Ian Jansen does a lot with, physical activity. And so he uses that to contribute to national report cards, and we can tell the percentage of kids that are meeting guidelines for physical activity. And it's not a pretty picture, and it hasn't been for quite a while. I'm interested in injury. But 1 in 10 young Canadians reported they'd actually experienced a concussion last year. Now that might be a bit inflated because there's mandatory reporting of concussions like symptoms in schools right now. So somebody gets bonked on the head, they may get shipped down to the DU or KGH to get checked out. So that might be inflated a bit, but we can study patterns of concussion. And we've got social indicators. This is really neat data, the first of its kind. This is the percentage of girls being reported being victimized during their dating relationships. And victimized to be either physically or in some sort of abusive manner. And you can see 37–40% of girls, grade 9–10 girls, are reporting these relationships. And so there's indicators of inherent violence within society at an early age. Really unique data. And we've got a ton of stuff on mental health. Loneliness increases with grade. Look at that gradient. And you'll see that gradient as kids develop, they're getting more lonely. And you see the gender divide that's there. And you always see this with the mental health indicators. Whereas boys are reporting having much more confidence in life consistently across the different ages. So it's reflective of broad things going on in society. And substance use. I got this thing about vaping. I'm sure some of you vape, but it's just exploded in the last 3 to 4 years. And I know it depends on what you vape and that, but like we're having 30–40% of kids now, by the time they hit grade 10, regularly vaping. So I really, really hope that it is a safe alternative to cigarettes and it's not the new cigarette. It's, in 30 years, we're not going to find out this is what cigarette smoking was like in the 1960s. But it's certainly an issue that's front and center at the Public Health Agency and Public Health Ontario and folks you may work with. So out of the national report last time, there were 5 main themes we took away. And the first of these, as I've sort of tried to demonstrate, the mental health of girls is, all of the indicators suggest that that should be a priority for our country and internationally, okay? The second is the influence of families. There was a positive message there. Most of the kids are actually reporting a lot of support at home and very positive family climates. But young people are also reporting when that's taken away, they're having trouble with the transition. As they get older, they kind of resent or the indicators say they really miss having that connection, having that oversight. So there's a couple of things going on there that are of interest. So the influence of family and the support one gets, the data tell us are important. Risk-taking is evolving. In almost all the countries, things like going out blackboarding, getting drunk, smoking, cannabis use, unprotected sex, they're all going down. And a lot of the public health people are saying, yay, everything's getting better. But we're seeing other types of risk emerged. So in Canada this time, we collected information on social media behaviors and things like internet challenges, things like going out on Tinder-like dates with a stranger, meeting up with them, you know, people taking overt risks that could put themselves at harm. Risk-taking is evolving. It's not going away. It's sort of a natural part of adolescence. Social media uses, young people tell us this, and the data tell us this. This is becoming more and more prominent. I don't need to tell you folks that. And then finally, the evolving role of gender. More and more young people are identifying with other identities that aren't white girl. Don't need to tell you that either. And it seems to be very strongly associated with health indicators, with young people who identify that way having much higher risks and much more challenged health. So a little bit about the importance of this survey and this survey opportunity to PHS, Public Health Sciences. Do you still call it?
Oh, yeah.
Just, yeah, okay. So it's used, I mean, there's reports generated from this data. I guess they're exciting. More exciting to me, theses and projects. It has been the basis of a lot of work, 499 projects, doctoral, master's work, and some MPH projects. It's the basis of peer-reviewed manuscripts, and it's the basis of an awful lot of tri-council and other grants to delve into these things much deeper. So do you know this guy? Do you know Ian? Some of you? Okay, Ian. Ian has been a collaborator on HVSC since he came here as a postdoc in early 2000s. I had the privilege of actually, I didn't supervise Ian. He's one of the brightest people you're going to come across. He supervised himself. But he's made major contributions internationally to understanding overweight and obesity in young people. And the fancy term now for physical activity is movement behaviors, studying how often we move our legs, how often we're sedentary, how often we sleep. He's also done a lot of work on the environment around us, natural environments and physical activity. And he led a number of methodological advances with our work. I put this paper up now here, comparison of overweight and obesity prevalence in school-aged children from 34 countries. This is work that Ian did as a postdoc at Queen's University. It is the most cited paper in our international network of 450 scientists. So it's impressive. He did it on a weekend. I gave him the data, and I didn't know Ian. I gotta tell you this story. Like, Bob Ross, who's in kinesiology, said, I've got this really promising person, would you help supervise him? So I meet him the first time. I said, okay, here's a data set. What can you do? Comes back after the weekend plumb, and there's this like beautiful manuscript, beautifully crafted things. Like I couldn't touch it. All right, that goes off to the, I think, Canadian Medical Association journal. Said, oh, okay, what can you do with this international data? Comes back after the weekend. Same thing, and it's just like this. I don't know if if science could have a Rembrandt. Dr. Jansen said he's a really talented. Yeah.
So you know he's on the Zoom room. He's here today.
Oh.
Yeah. So he's probably blushing. Yeah. So maybe in the Q&A you could get.
Okay. Well, I think a lot of you. Moving on. One of the interesting parts of that analysis that he did was he showed the fundamental importance of these movement behaviors in driving overweight and obesity in kids, and showed in almost all countries there was an association between the amount that kids were moving their legs versus what they were eating as the primary determinant. And sorry for pointing out. He also led a study on the built environment child movement, and obesity. Basically, I think it was the 2010 survey, every school created a geographic information system buffer around that school and then measured things like green space and sidewalks and all sorts of aspects of the environment, and then related that to physical activity, obesity, injury, violence, and all sorts of things. So a major CIHR study. You know, call Dr. Davison, Colleen. She's been involved for about 15 or 20 years. Reflection on her contributions. She brought a lens of health equity to our research team. Very interested in sort of child's rights and engagement. Was one of the first people that brought the youth voice to the interpretation of our data through youth engagement. Very interested in social environments and health, and has most recently brought new indicators of food insecurity that are going to be actually quite interesting to look at in this latest cycle, and an interest in immigration and health. I just picked one of her many papers. This is sort of looking at the contextual environment of children, social supports, and actually understanding their influence in unexpected health states. This got cut off, but these are relative risks. These are the kids who were socioeconomically disadvantaged in that survey. So these are all kids that are quote unquote poor. And it showed the relationship between having supports in their social relationships and excellent health, irrespective of the fact that they were from disadvantaged backgrounds. I think that's an important piece of work. She also led a CIHR grant on, I called it health promoting home environments, but basically the home and qualities of the home that determine health. You won't necessarily know Mike, but he's adjunct still. He's at UPEI. Biostatistician, was here for about 5 years and is still a member of our team. He contributed a lot to how we approach missing data analysis and the use of imputation. And called intersectionality theory. Just show of hands, you ever heard of that term? Are you taught? Okay, actually how to do that quantitatively. And causal models. He's really interested in music and its role in the health experiences. So he's brought some music items, which are kind of cool. And also has a health equity lens to his work. He figured out how to model this. This is intersectionality. And what it's saying is that there's your position in society, they call them social locations, are the intersection of your things like your gender and your race and your SES, things going together. And then that position is associated with behaviors and processes that either marginalize you or privilege you in terms of your health. Anyway, he figured out how to actually causally model that in mediation models, and it's pretty cool. And he's had an important role in a grant that's actually delving into this gender patterns that we're seeing and why girls especially seem to be disadvantaged. Wendy Craig is not in public health sciences, she's in psychology. She co-leads this with myself. Really, really interesting, accomplished scientist here at Queen's. She's led international efforts on bullying, violence, and healthy relationships. Interested very much in sort of peer relationships and supportive environments in health. Really interested in seeing our work turn into policy. And she is part of the national and international leadership of HBSC. Here's a recent example of work that Wendy and myself did. She is actually having a hard look at social media use patterns that we see and how it relates to experiences of violence online. You can imagine if you're online a lot more, you might have more opportunity to have some negative things happen to you. So she's done analyses, or we've done analyses that have looked at sort of intense use of social media and more addictive, problematic use of it, and how it relates to various indicators of violence in kids' lives. And these sorts of data, HBSC is the foundation for this thing, PrevNet. You heard of PrevNet at all? Is that ringing a bell? It's an NGO across Canada, anti-bullying, positive, for trying to promote positive, healthy relationships. And you need a foundation of evidence to do that. I think there's something like 50 different NGOs involved in this broader NGO, and it's a pretty important group. Again, out of Queens, and HBSC is one of the platforms used to support it. Myself, I've done stuff on injury, risk-taking, violence, determinants of health, and really actually interested in a new set of items we've got, trying to measure the inner child's spiritual health. Maybe not what you think. That term's a bit loaded, but actually looking at the deeper connections in one's life and how it connects to health. I've got a new grant looking at these contemporary risk-taking items. And we have a grant looking at these connections, these spiritual health connections in life and their roles as determinants of health. So just to end with a little bit of reflection on the importance of this study. HBSC is a very unique surveillance tool nationally and internationally, just to keep track of health and health behaviors in kids. It's a platform for innovative etiologic research, whether that's Ian's built environment work or Colleen's health equity work or Wendy's work looking at determinants of violence. It's a major focus for collaboration on this campus, across the country, and in the network. And it's a really cool training tool for theses and for students. So a few opportunities that if you're interested, if you're interested in movement behaviors and physical activity, if you're interested in obesity, there's items there. If you're interested in social determinants of health or health equity, there's items there. If you're interested in the experience of new immigrants, if you're interested in violence, if you're interested in military health, that's what you're doing, Isabel, right? Military health. One of our colleagues is actually in nursing, has an item, we can identify the kids from military and veteran families. If you're interested in food insecurity, so a broad range of topics. And then methods, you could do descriptive stuff, sectional analytics stuff. You can merge the data and do multi-level modeling. It's used in mixed methods where qualitative and quantitative come together. GIS, these cross-national comparisons, scale development, psychometric stuff, and causal mediation analyses, figuring out deeper causes of health events. So just a few examples, then I'll wrap up. I asked my colleagues, give me an example of something going on. So Adash from UPI, they're looking at the well-being of 431 adolescents who self-identify as having eyesight problems or they're blind. I'm working with a PhD student right now, Valerie Pagnata, really interested in sleep and sleep hygiene and how it relates to injury. And has done a couple of papers, one cross-national on that topic. Wendy's worked with a PhD candidate out of psychology and looking at the role of social supports in affecting relationships between bullying and mental health. I mentioned, do you want to talk about your project? No. Is this correct? You're looking at school belonging, basically school achievement and school belonging in the military kids and comparing them with other kids? I don't know. Yeah.
And like school satisfaction, which I guess, school belonging.
Yeah, really, That's actually a unique opportunity in that you got a fairly robust sample, if I remember. You know, at least it's into the thousands, of children. Yeah. Ian in the past has worked on sort of the environments, and one of his PhD candidates did food environments. So, you know, the number of fast food restaurants and sort of the environment surrounding children and how that affected obesity. And then the last one is Manisha. I don't know if Manisha should be here because I think they finished up, but was interested in immigration status, racialized status, and depressive symptoms using an intersectional lens. So those are 6 concrete projects that are either ongoing or just happened involving these data that public health sciences had a arm on. Through the years, master's or PhD theses, I counted up 60 to 70 of them have come out of this department, hundreds of student manuscripts. There's been dozens of tri-council and other grants that use HBSC as a platform and hundreds of students involved. So three take-home messages. All I cared about at the end of this, you now know about HBSC if you didn't know it before. Message number 1. Message number 2 is it came out of Queens in Canada and it's got a 35-year history here. So it's part of your community and your heritage here. And its research possibilities are very deep and rewarding. And it's been a wonderful project to collaborate on with lots of really good colleagues for a long time. That's it.
Time for questions. Dr. Pickett, do you want to field your own questions from the podium?
I'll do that. It probably will be useless on the Zoom, but yeah. Anybody got any comments or questions? Yeah.
You mentioned some of the new indicators that you thought would be really interesting. What are some things that haven't been included that you would like to see added in the future? Aside from gender diversity, which has political elements.
Yeah, definitely a better measure of gender diversity. It's funny in Canada. You either get hammered for not including it well, or you get hammered for including it well, depending on the jurisdiction. Just a couple of things. I've always wanted suicide and suicide ideation questions to be on this. Tried to get them on for probably 20 years. There's a thing called duty to report. If a kid reports that behavior, you're supposed to do something about it, and it's really challenging for the schools. But other surveys do it, and I'd really like to see it there. There also seems to be, and I don't really know what to make of this idea of climate anxiety, and young people's anxiety and worry are rampant in this demographic. And that seems to be a real flashpoint for anxiety. So there's some modules that have been created we could ask about that. One of the challenges, it's grade 6 kids, 11-year-olds, they only have so much attention span. So you can only get so many items on in a period. They're always sort of fighting over space. That's a couple examples.
I have a methodological question. This is done in schools. Do you get pushback from parents at all? Do you have to get consent from parents to for this? And how do you do it internationally?
So internationally, they leave the ethics and the ethics procedures to the national team in their own institutions. So in our situation, we have permission to use the consent process that the local school board requires. So there might be, I don't know, 100 or 150 school boards across the country we're dealing with, and it depends on their protocol. So some require you to have active consent from the parent. So you send basically a piece of paper home, and they have to sign it, read the stuff, sign it, bring it back, and then the kid can do the survey. In the vast majority, it's a passive consent. Basically, they'll broadcast out that this survey is going on, and as long as nobody objects, the child can complete it. We usually have half a dozen a year where you'll get major complaint coming, either to our ethics board or to us as investigators, where they don't like the questions. They don't want to see sex questions on. They don't want to see drug questions on. Very conservative views, and they're a challenge. But by far the majority of kids fill it out. It's pretty good.
I'm sure we can't just pick this data up and actually do our own analysis. We have to go through a process of actually getting it. I can imagine that just the analysis, you probably have to wait, bootstrap, do all that stuff. How do we get access to it?
For the Canadian data, after 3 years, it becomes open access, but there's a permission. So you basically have to write Dr. Craig or Matt King, who coordinates it, and ask for permission. And then usually that's granted. Internationally, you have to go, it's run out of Bergen in Norway, and you can apply online and get the protocol and get the data again after 3 years. So we as investigators get the first shot at it, 3 years, and then after that, it becomes open access. But there is a process to get it, so. But certainly possible, but. Yeah.
Sorry, I just have a question from from online. So for Matt Jolling, has there been any interest in the health behavior of homeschooled children? And was there a way to capture these children in your survey?
Yeah, I should have said something about that. There's certainly interest in that. In Canada, this is a survey of the quote unquote public system. So it would be kids that actually go to school in the public boards or the separate school boards across the country. We don't have private schools. We don't have incarcerated kids. We don't have kids that are on the street or homeschooled. The children make up about 93 or 94% in the regular boards. It'd be super interesting to do. It'd be super hard to do. But we don't have data on homeschooled kids.
It's an online question too.
So that's the one I've read, but there is one
Oh,
from
yeah, there's a hand.
John.
John Q, it looks like.
Can you hear me well?
Yeah, how are you?
Hi, it's so nice to see you again.
Yes, well, I can't see you, but thank you.
I'll see you this evening. I've got a question. It's becoming more and more jarring to me to just see that binary girls, boys, males, females over the past year or so as I've been exposed to research that involves folks that are non-binary. Can you talk a little bit about how moving forward, at least in Canada, that data, that information is going to be collected from the kids?
Yeah.
Or is that something that is just so difficult right now that you're not touching it?
No, we are. And I would say in 90% of our school boards across the country, we have new items. We ask sex at birth and we ask a new gender identity item. We can identify kids sort of indirectly that would self-identify as trans by looking at sex at birth and their gender now. And we found that the percentage of kids, we're up into the many hundreds of kids who are self-identifying with a gender diverse category, to the point that in our reports nationally, we're going to be able to actually report on their health this time around. There's enough there that you don't have confidentiality problems.
Oh, that's encouraging.
Yeah, it is, but then you still have school boards across the country that won't let you ask that question.
Yeah.
Question over here.
Thank you for the past presentation. I have two questions. One is about ethnicity and
Yes.
how ethnicity data is collected. And in relationship with that, if there's any information about Indigenous adolescents or schools in reserves and that kind of information, that's kind of a big question. And the other is if there's any access to a metadata repository where researchers can see which variables are being collected in the survey. Two separate questions.
What's going on there? Ethnicity, there is a standard item adapted from StatsCan, has 14 categories. It includes 3 Indigenous, I think First Nations, Inuit, and Métis. So the kids can self-identify with those heritages. We oversample in the north, so we actually have a pretty robust sample of Indigenous. None of the research team in Canada have been positioned to have the partnerships in place to do that right. So that data is there, but it has not been acted on, but it's there. We can't break things down officially. Or we break OCAP principles and we break how you're supposed to handle, but any unofficial look at it is that they have some interesting health experiences that are quite different. So does that answer your question directly?
Yeah.
Yeah, it's there. In order to actually use it, you probably have to go through a different ethics process here at Queen's and have the right partnerships in place. So we just haven't done that.
Take time for one more, probably.
We have one from the audience, unless there's one in here. Nope. So Dr. Johnson has said she's curious as to why the US has been no longer participating, perhaps political reasons. Also for internet use going up, what does intense use mean? How many hours per day?
Sure. So that's Anna, is it? Yeah. Hi, Anna.
Hi,
Okay.
Will.
Hi. All right. Short-term memory's gone. The intense use is basically if you're awake, you're on it. You're on your device. That's intense use. And 30, 40, 50% of kids are reporting that. They've got their phone and they're on it all the time. And sorry, what was the first part of the question?
She just said she was curious as to why the US had no
Oh,
participating.
yeah, the US model of research is really different than ours. And they had to get peer review funding. They had it and they lost it. And they could not replace it. And their survey probably cost 10 times what it cost us to do in Canada to do the same survey, their model. And they did have a change of government and less investment in adolescent health research. So they had to drop. It's too bad.
Thank you, Will. Political repercussions, yes.
I think that we're scheduled to end at 1:20. We're a little bit over. Please give me